So I'm going to be speaking from a radiologist's perspective. And these are my disclosures. I was the site PI for RCT that was done across 5 sites, looking at the cancer detection rates, comparing cancer detection rates on conventional truss versus microultrasound. And then we're now going to be starting doing a feasibility study to see if this is possible, if we can do focal laser ablation under microultrasound. So we know that conventional truss using the 6 to 9 megahertz platform is not sensitive. And that's why for all the years we've been doing systematic sampling of the prostate, evenly spaced your needle, in the hope that we catch a big enough cancer. MR is sensitive. There's been tons of evidence in the last 5-7 years. It's perhaps it's an expensive tool. It's not real time. PSMA, it's very sensitive for extraprostatic disease. I'm not sure if it has any benefit for detecting intraprostatic disease in a well-read multiparametric prostate MR. And that brings us to microultrasound. There's some evidence building that it has good sensitivity in detecting significant cancer, and it is real time as well at the same. So what is microultrasound? We've heard about it yesterday. It's a very high resolution ultrasound which operates at about 29 megahertz as opposed to 6 to 9 or 6 to 10 megahertz that we have conventionally been using for the last 10, 15, 20 years. Provides 3 times increased resolution down to 70 microns. And during our initial RCT, we developed a Primus protocol, which is very similar. We were trying to emulate the PIRAD scoring pattern, 1 to 5. Higher the score, higher the chance of harboring clinically significant cancer in that particular sonographic pattern that we described in our Primus protocol. So coming to MR, we know, and this has been discussed this morning as well, it is extremely good and extremely sensitive for index lesions. So larger lesions, as Dr. Stern had mentioned, a volume of higher than 0.5 cc's. We know that 95 to 96% of those index lesions, if they're clinically significant, are going to be picked up on MR. But perhaps it's not as good for picking up satellite lesions, the secondary lesions, the non-dominant lesions. And there's been evidence that we do underestimate the tumor volume on MRI. This was shown by Dr. Margulis's presentation yesterday as well. DCE is perhaps the best sequence to estimate the volume, but we know that we underestimate. And the fact that we don't pick up satellite lesions and the fact that we underestimate the true volume of the disease, it brings in that uncertainty when we're selecting patients for focal therapy as well. You want to be sure that you don't have significant disease elsewhere in the prostate if you're going to be doing a targeted kind of a focal ablation. PROMISE study again, I think we've discussed this morning, and as was mentioned, the negative predictive value was about 76%, but we realized that the overall cancer risk in that cohort was about 53%, and if you look at that, there was a risk reduction of about 55% with a negative MR for any volume 4 disease on biopsy using template biopsy. So moving to microultrasound, the first studies were done out of Johns Hopkins, comparing high-resolution ultrasound to low-resolution ultrasound in patients who were already consented for a radical prostatectomy, and the detection of clinically significant cancer or all cancers was significantly more on those prospective calls on the high-resolution ultrasound as compared to the low-resolution ultrasound or the standard conventional ultrasound that I've been using for many years. There is also some early evidence that certain sonographic patterns that have been described in the Primus protocol do correlate with specific pathology. Just because of the increased resolution, we have seen that a certain pattern where it's a hypoechoic lesion, but there is irregular shadowing from the lesion, has often been seen to harbor cribriform pattern on pathology. We have also seen that when we see a starry sky kind of an appearance where there are multiple echogenic foci, they've come back as comedonecrosis on pathology. In some of the samples, sonographic patterns where a cauliflower pattern, as we described, or clumps of echogenic areas with a hypoechoic margin have come back as dense tumor on pathology. Again, very early, small data, but very promising, the dense tumors that we generally see on MR. There have been a few studies now comparing microultrasound to MRI. I think the largest cohort that has been published as yet is from Milan in Italy, where Dr. Lugazzani and his group enrolled 104 patients. They all had to have a positive MR, so a call of a 3, 4, or a 5 to be entered into the study, so there's a bit of a bias here for MR. There were 35 patients. If you look at the flow chart below, there were 35 patients in that study. Out of those 104 patients who had clinically significant cancer on biopsy, 33 of those 35 were picked up on microultrasound. And there were only 2 which were missed on microultrasound. So there was a 72% reduced risk of harboring clinically significant prostate cancer with a negative microultrasound in that particular study. And this is just to show a meta-analysis of 5 different studies, a very heterogeneous cohort at this time. There's a slight shift favoring microultrasound as compared to MR. Only 280 patients, 5 different sites. The largest has been a 104-patient cohort from the group in Italy. And again, very heterogeneous. They were not all biopsy naive. They were not, some were on active surveillance. Some were after first biopsy. We, at present, at Princess Margaret Hospital in Toronto, we're running a prospective study. We were successful in securing a grant for a 100-patient study. It's a non-inferiority sensitivity for microultrasound to detect clinically significant cancer versus MRI. Only biopsy naive men are being included in the study. We have enrolled about 13 or 14 patients. I have results for the first 11 patients here. Significant cancer was seen in 8 of those 11 patients. They were all biopsy naive. 7 of them were picked up on MR prospectively, and they came back as clinically significant cancer. And microultrasound was prospectively able to see 6 of those 8 lesions. Again, early results. We'll be enrolling 100 patients in this study. So this is an example of one of the patients from our study. You can see there were 2 lesions called the right anterior peripheral zone, as well as at the apex, and the right posterolateral peripheral zone at the apex. And we can see both the lesions on the ultrasound as well. So as a SAG, it's going to stop when you start seeing those 2 lesions. If you can appreciate the right anterior lesion and the right posterior lesion, if you were to take an axial plane from that, just from that side, you'll probably see it in a very similar way as you see it on the MR. So what do we do at present when we do pick up a lesion on MR? There are different options. I think the best and the ideal option is if you can biopsy in bore, in real time again. You'll be 100% sure that you're sampling the site. You can visualize your needle, but it is expensive. There's a learning curve. It's not so readily available at all the sites. Or else we go to cognitive or a software fusion technology. And this is the future trial, which did not show too much of a difference between the 3 techniques of doing a biopsy following an MR. And a recent study, and this was done in France using the microultrasound, and they did find that there was a significantly higher detection rate on MRI-targeted samples with microultrasound as compared to robotic elastic fusion. And this really is because even if you did not prospectively see the lesion, when you go back and you do have an MRI and you go back with the high resolution, most of the times you will quite definitely be able to see the lesion. And if you can see the lesion, you're again sampling that site under real time, and you're not relying on a fusion technology to tell you where to put the needle in. And that's another big advantage of using the microultrasound device. So to conclude, it provides promising correlation. There is early evidence which is positive. Larger prospective studies are underway. How will this technology be used? I think it's going to decrease the burden on MR. There will be many patients who will go on to have a microultrasound biopsy and may not need to have an MR. Plus, I do think that it has promise in the fact that it will decrease the need for fusion biopsy as well. Because even if you were to use this after an MR, most of the times you should be able, with some learning, to visualize the lesion. Thank you.